Well, welcome, people. We'll still give a few moments for other people to be added. Welcome to the SDFM webinar. And today's webinar is on structure and funding of residency programs. So at the series, this is number 2 of an 8-part series for the Faculty of Tomorrow Task Force. The Faculty of Tomorrow Task Force is a group of people who are in residency programs, some faculty members and some program directors. And really it's a group that has been convened for 2 years to do some initiatives to address the pending shortage of faculty for family medicine. We are hoping to expand the recruitment efforts of residents who want to become faculty members and doing some professional development for them, providing resource and training for faculty from other sources, such as people coming out of practice who might want to consider going into academic family medicine. We help identify some family physicians with leadership potential and make sure that the leaders of institutions where family medicine residencies are located, they understand the time and the competencies that are needed to become a faculty member. And so today, I'm Wendy Biggs, and I am Associate Professor and the Residency Program Director at the University of Kansas School of Medicine in Kansas City. And Tom?
Hi, I'm Tom Miller. I'm an Associate Professor and a Program Director for a Family Medicine Residency Program in Quincy, Illinois, affiliated with Southern Illinois University. Happy to have you all. Thanks for thanks for joining us.
So do you want to know there is a dialog box on the right that you can type in some questions. We'll be happy to answer those questions as we go. We have our monitors from SDFM that will be looking at those questions. We talk about finance and funding of residencies. There are always lots of questions, so feel free to type away. We'll try to get to some of them here, and if we don't get to all of them here, we will go ahead and try to get your answers to you at a later time. So what we're going to do, Tom, you want to talk about the overview?
Yeah, absolutely. Be happy to. So just to kind of talk about what we're going to try to accomplish over the next 1 hour, and please realize that we're giving you a 30,000-foot view here. We are not going to be able to accomplish or have you understand all of the intricacies of family medicine residency funding over an hour, as there are many weeks or months that people can spend on it. But we're going to give you hopefully some tips and some tricks and some ideas which will help you along in your education. And plus we're here to help you in any way that we can. A couple of mantras that we'll talk about. One that is dear and near to the heart of many in family medicine education is that if you know one family medicine residency program, you know one family medicine residency program. However, with that said, there are some common things, and we'll try to explore those. We'll talk about common expenses, common funding, a little bit how the structure of your program and how it's set up will affect finances. We'll talk a little bit about stakeholders and identifying who the stakeholders are in your system. And we'll talk about how you can learn more about this topic if you want to learn more about this topic, including some really good ideas for maybe a project to help you along in your quest to become an expert or at least have a better understanding of residency program finances. So we sent out a pre-webinar survey, and we really appreciate those that took the time to respond. If we looked at those that responded, about 2/3 of them were faculty, and about 4 to 5 or 80% of those were in community-based programs with some type of university affiliation. Additionally, it was primarily a suburban or rural environment that their programs were in, with about 8 out of 10 being in those kind of areas. We're happy to say that our pre-webinar survey included about 1/4 of residents or fellows Also, I'm really happy to say that many of you felt really good about joining or becoming more involved in an academic career, that it would be good for you, good for your lifestyle, and good confidence that you can succeed in that regard. So we're happy about that. It's also good that many of you felt that you had some base knowledge of organizational structure of academic family medicine.
So we're going to be taking a poll here. Please let us know who's on right now, since some of you may have not done the webinar or pre-survey.
Yes, and this is Emily Walters. I'm with STSM, and we're kind of running the poll here. So we're just going to give it a few more seconds so that we give everyone a chance to figure out how to do these polls and you know, get your vote in. It's really helpful for us to know kind of who's present and what kind of concerns we might be addressing. All right. What do you think? Should we go ahead and close it now? Mm-hmm. All right, so we should see our results here. Looks like we're pretty consistent here. We have a lot of faculty present, which is just great. It really makes sense that as faculty, these things directly affect you. A good number of program directors as well, 11%, and 6% residents or fellows, and of course others as a broad category, but we're glad to have you here. I know there's many other roles that you might have and be interested in this topic. All right.
So Tom?
Yeah, so key financial skills. You know, the first line is something that we put in there somewhat to just understand that I tell my residents that either fear can paralyze you or motivate you, and I encourage them to let fear motivate you. Let it develop an increased sense of your awareness and things like that. And I want the same thing to happen with finance. Don't be so paralyzed by it. And if we talk about what each level needs to know, again, a good proportion of the people here are faculty or those that are even higher up in the faculty realm, either program directors or assistant program directors. But kind of having a sense of what each level needs to know. So if you're a resident considering academic family medicine, my own personal feeling is I want residents to focus on how to learn and how to really do an excellent job caring for patients as their main focus. And I want them to kind of realize that, hey, all this other stuff happens seamlessly. But as they progress along in their residency training, maybe near the end of training like I have them now, I want them to have some understanding that if you don't run your business well, you can't run your business or your program at all. So one of the mantras, again, that we'll talk about is no margin, no mission, meaning you need funding and things to do things. Now, if you get to be in the faculty member role, and we're excited that many of you are, and hopefully those that aren't may be considering that shortly or somewhere down the road, it's going to expand beyond the no margin, no mission. Actually, the easiest expansion is no margin, no mission, no paycheck. And that gets people's interest a little bit. But again, as you crawl up or as you climb the ladder, hopefully not crawling, but climbing the ladder from beginning faculty to more advanced faculty within a program, it's really important that you understand that there are some skills to learn. I also want my beginning faculty to know that they need to be to realize that they're vital to a health system. Presently, family medicine is the highest recruited specialty in the country, and so as either a new family medicine doc or someone who's been out there for a while, you are vital to health systems, and you are valuable. So realize that and embrace that. Don't let the people in upper level kind of enhance this fear in you. Don't feel that way. As a new leader, understand that. Plus, get a better sense of the finances of your present program. Now, one of the things I'll talk about a lot is partnering or hiring someone who knows this well, who will work intimately with you to be someone to help you along that journey of learning about how your program works and family medicine programs work in general. Okay, so terms in funds flowing is something we'll talk about, and understanding that hopefully your monies in are greater than your bills out. Again, no margin, no mission. So we're actually not going to go through and teach you how to read a financial statement, because what we really want you to do is get the big picture. In some ways, I liken it to a cellular phone. I have no idea how each of the transistors work, but I know if I press that on button, it's able to really give me some valuable data and allow me to do some good things. So understand the drivers in your organization, understand your budgeting process, and again, becoming a partner or hiring someone who really does know your finances well, that you can work with an expert, a CPA or an MBA or somebody like that. Okay. Now again, we talked about funds flow in the last slide. So we're going to talk about funds flowing out first. And if you want to think about this in a general term, I think about it a little bit like a business and a home. So in any business you have expenses, salaries and benefits for you, your faculty, your support staff, your people you need to work with for the community are going to be one of your biggest expenses. It's also important to understand that for every dollar that you pay in salary, you're going to pay 36 cents in benefits. So that means if you pay someone $100,000, you're really not you're not really getting $100,000 in expenses. You're having $136,000 in expenses. But salaries, technology and equipment is becoming, and this shouldn't be a surprise to anyone, a significant portion of your expenses now with electronic medical records, hardware, softwares, things like that. So be savvy about that. Don't be afraid to negotiate. Work with things to minimize your expenses. Interfaces is the big word now. I think about it as a graduate, and I talked about plastics. If someone wants to get into something, it's interfaces, because all these programs need to talk to each other, and an interface seems to be the way of doing that. So if you think about a home, the next line I talk about is bills. And so you're going to have bills. You're going to either have a lease or a rent expense. You're going to have supplies, utilities, water, electric, gas, internet. You actually have to pay for someone to clean your space, to repair and maintain it. And then you have other things, again, that you might not think about. You'll have things like billing and collections, human resource people, purchasing, accounting, audits, other things that you need just to be adapted, travel and licenses. You'll have expenses for your business like recruiting and advertising, and things like insurance. You'll have to have malpractice insurance and other types of insurance, but you also may need legal support or legal people to work with contractual things that you may be working at or other things. So you want to get a sense of your expenses in your program. Beyond these very perhaps obvious expenses or some other expenses, sometimes we even call these unfunded mandates, because these are things that you have to do that may not lead to directly increasing revenue. Research may be one, having other learners, or when there are changes to residency program requirements or your own area. For example, if you expand your residency and now you're serving a population that requires you have interpreter services, that may be a new expense. So you always want to have a little bit of your funding in some understanding that you need a rainy day fund, or you're going to have some contingencies and things that pop up that you may not plan for. But you clearly want to get an idea of what your expenses are. So before we move on, I'm going to break, if we could, and see if there are any questions that we can address at this point in our webinar.
This is Emily Walters again. Right now we haven't received any questions. I'll kind of monitor that screen, and audience, if you want to send anything in that you can think of, we might bring it up at a later time as we move through our slides. But just know that you can be sending them in as we go.
All right. Then what I'll go on to is the other side of the balance sheet, which is the funding. Of course, with the, like I said, the margin is you'd like more funding than expenses. Certainly, clinical revenues are an important part of the funding. The clinical revenues come from both the faculty clinical practices, the hospital service, the residence clinics, and so all that clinical revenue really is a significant portion of many residencies' budget. The money that is always confusing to people, of course, is the federal funding, the Medicare dollars. Residency is tied to Medicare. There's something called direct GME. Some people call it DGME or DME. This is actually money from Medicare, which is intended to cover the cost of training the residents, the resident salary and benefits, supervising faculty fees, things like that. And actually, Medicare gives about $10 billion, that's billion with a B, dollars per year to support residency education. That's in all specialties. So the DME, the direct GME dollars, tend to be about 30% of that. So the other significant portion is the confusing part, the indirect medical expenses, and that's the IME. Now, IME is an added part of every billing to Medicare that comes from that teaching hospital. It's calculated with a very complex formula that is based on Medicare beds and the full-time equivalents of residents that are present. And I will give a website in a second that if you're more interested in that algorithm to look more into that. And then again, that's about $7 million. Some states actually will support residency training also through either Medicaid, DME or IME, or sometimes some states have an inline budget, you know, where the state government has decided to support the family medicine residency. Some have supported rural funding, and to do that more specifically. These are the podcasts that are by the AAMC, and they, on the right column of those web pages, there are videos that go through. They're very short and very simple to watch, that explains the direct and the indirect GME. They also talk about residency caps, and you'll hear a lot about residency caps. The cap is on the direct GME dollars, the DME. It was actually established in more than 20 years ago, in 1997, and so each hospital at that time, however many residents they had, that's what the cap was set at. So as you can imagine, as population has expanded, as hospitals have gotten bigger, there doesn't seem to be as much residency money in direct GME coming to those institutions. So these are explained in those videos if you wish to have more in-depth knowledge about GME funding through Medicare. The residencies also are funded through the hospital. As we said, the hospital, not the residency, the hospital receives the IME. Some residencies are funded through trusts or through some educational consortiums, but the IME still usually goes to a hospital. So there'll be some type of pass-through from the hospital healthcare system to the residency to help support that. For many residencies, they often try to find out from the hospital how much money they're actually getting, and they're actually, if you go to the Robert Graham Center website, there are some links that you can go to find out that money. It is public knowledge. For residencies that are attached or affiliated directly with medical schools, there may be some money for the residency for teaching of those medical students through clerkships or other teaching that the residency faculty may do. such as problem-based learning sessions or other types of medical student teaching. Certainly, federally qualified healthcare centers and teaching health centers have different financial formats than a traditional hospital-based residency or community hospital-affiliated residency. The teaching health centers were part of the Affordable Care Act, the ACA, and they were given a 5-year funding associated with that. It is not permanent. They actually did get Congress to approve something to continue the teaching health center funding of residencies, and there actually are about 600 to 700 residents, primary care residents, that have been funded in the Teaching Health Center Act, and so that is a good source of funding right now, and there actually is some bipartisan agreement to continue that, and so hopefully that will continue through the future. Contracts and grants for some residencies. For instance, our residency has a contract with the Kansas prison system that we actually do some quality assurance and quality chart review for the prison system. Grants through research or grants through other community foundations may provide a very significant portion of some residencies. And then, of course, there are some innovative models. I mentioned some of the teaching consortiums, but other communities may have some other ways in which they support the residencies that are in their hospital and in their communities. So one thing we wanted,
Oh, this is Emily. I was just letting everyone know that we had a poll coming up. Go ahead, Wendy.
So this poll, what we want to talk about is the stakeholders. So this is the most important. So you as participants, who do you think is the most important stakeholder for the residencies? This is an opinion question.
All right, we've got some answers coming in. I'm pretty interested to see what everybody thinks. Oh, and we're kind of evening out our responses. All right, what do you think? Let's go ahead and close this poll and see what results we got from everyone who voted so far. Okay. All right, so here are our results. Okay, so we've got, looks like a majority thought that the residents are the most important stakeholder. Looks like hospital came in second, faculty third, and government fourth, and medical school last. What do you think, Wendy?
Well, I think that certainly for the residents, their stake in this is their education and their future career, their training. So, but as a financial stakeholder, they're more of the stakeholder in the educational process. I mean, certainly the hospitals tend to be the financial stakeholders. But Tom, do you want to talk some more about that?
Sure. You know, I think, Wendy, you're absolutely right that, you know, but I think this also displays the idea that there really is no single answer to this question. And the most important thing in your system is to know who these major stakeholders are and to know how this all relates to your expenses and revenues. Like I said, I encourage you to have the attitude that you are doing something that's really very valuable, and you're going to be going up on and they call it the C-suite, the corporate suite, and sometimes we call it meeting with the soups, and it usually means the people that wear suits all day. And sometimes it can be very intimidating with throwing a bunch of Excel pages at you and showing you different things and asking you all these accounting terms. But realize that when you're in these discussions and these relationships, one, don't let them see you sweat. It's kind of like if you have a shoulder dystocia or whatever. You got to plan out what you need to do. You got to practice. You got to be comfortable, work the whole team, and do the whole thing. It's the same thing with when you're doing these negotiations. Realize who these stakeholders are. Realize that you're valuable and you're an important part in this. And realize that you are worth something and get what you can out of it. As Wendy said, one of the things that happens is pass-throughs. Some hospitals will pass through 100% of IME to residency programs. Some hospitals will not. And it's important that you go armed with your Robert Graham information. You don't necessarily want to show your cards right away, but you go armed with it so you know approximately how much money the hospital is getting from Wendy, which you talked about with DME, but also IME. And so when they're saying the discussion, we're not getting anything from the residency program, you guys are just costing us more money, you can say bull hockey. And you can say, for each one of my residents I'm putting out in your system, you're saving an inordinate amount of dollars and you're doing great things for your community. And so you have to be prepared, you have to be, not belligerent in your conversations unless you need to go there. But you need to be comfortable with understanding that this is an important thing and you need to be prepared. But know who your stakeholders are, know how to relate to them.
So you may ask yourself, how do I get some hands-on financial experience? Certainly, even residents can do a small budget-related project. There may be something that you can go to your program director and say, I would like to learn more about finances. I'm thinking about becoming faculty. For the program directors, they would love to promote that interest. Maybe there's a small project that's going on, maybe a community-based project or an educational project that has a budget with it that you can take on and go through a budget sheet with either the administrator of your residency or the program director or another faculty member with financial experience, that you can actually sort of sit down and get the nuts and bolts on figuring out how to read the budget sheet and to manage a budget. Some residents have had vast experience before they go to medical school and residency. They may have actually run their own business. I've had some of those residents, and they've taught me about the residency budgets, and that's okay too. So, collaborating with faculty and program directors to learn and teach each other is really the heart of a residency program. I think, are there any questions?
All right, this is Emily again, and we have received some questions. The first one that I'll kind of give to both of you as panelists would be, can you talk about DOE for PDs, associate PDs, in relation to ACGME requirements?
We talk about.
So the question was.
To explain what DOE meant.
I guess I'm not sure what that meant in that case. We're going to ask.
Maybe DME?
Oh, I wonder if it was a typo. How about we try another question?
Auto-corrected.
Yeah, it might have auto-corrected. Maybe I think DME would be a reasonable assumption. So for that question would be, if we assume it's DME, for PDs and associate PDs in relation to ACGME requirements, what do you think?
So I'm wondering if this is related to administrative time and how is that paid for. And if this is not true, the person who's listening, go ahead and type again and maybe clarify your question. The ACGME program requirements actually require the program director to have dedicated time and no more than, I believe it's 40%.
3 half days.
3 half days, 27 hours type of thing, 3 half days of their own patient care. So the rest of the time should be devoted to residency administration, teaching, and what we call scholarly activities. That could be research, that could be presenting, that could be doing a webinar like this. For faculty, when there's core residency faculty, that's an ACGME definition, and they are 40%, to be 40% non-personal patient time.
60%.
Right, and so only 40% they could have their direct patient time. And so the question is, how do you pay for that? Well, it is actually a sort of a, I always say it's a cost sharing, in that the clinical revenue often has to be flexed to cover that. I mean, if we're all helping each other, there are other maybe more clinically productive, meaning in time in the clinic more, the faculty may be doing that, or it is looking for those other contracts or other ways to support that. Certainly negotiating, as Tom said, with the stakeholders of the hospital to see, to support the educational mission of the residency may need to occur to try to support that. DME actually does not, is not earmarked per se for salaries of the faculty or program director. When it's usually about $100,000, give or take $30,000, depending on the area of your country. And as Tom said, if it's salary plus benefits, there might be a little left over for some support of non-clinically generating time, but there's not much.
Right, but this is where you use your program requirements to help you, quite frankly. So if you have a hospital saying, well, why are you doing, only 3 half-days if you're a program director of patient care, or only 4 days if you're a core faculty member. You should be seeing patients, 6 or 8 half-days per week. You could say, actually, I want to be very clear that our program requirements require that we dedicate this amount of time to the residency training program. And again, how I approach this is I say, this is time that the hospital needs to fund the faculty. If the program, and this is where you have to be careful, because they could say, all right, we don't want a program, and they'll let you go. So you have to kind of have a sense of where they are with wanting you or not wanting you. But if they want you, then they have to fund you. And you're right, what Wendy said, you'll have some faculty or higher generators than others, and that's a way to pay for some of your expenses. But also realize that this is a core requirement of your residency program, so you must have it. My feeling is those have to be funded by state funds or hospital funds or federal funds. You're not going to get direct federal funds in most situations. So I think those should be funded by the hospital or the state. Now, some hospitals are going to do that and some aren't. My feeling is you've got a pretty strong footing to go to your hospital and say, hey, these are requirements to us to have a residency program. If we want to continue to do that, we're going to have to find a funding stream to be able to do it. If you look at your IME along with your DME, again, some people argue, well, IME isn't directly related to a residency program. You could say yes, but if you don't have a residency program, IME goes away. So you just have to be prepared to have these conversations. Again, your accountants up there, they're getting paid to make the hospital either money or not lose money. And you are a little bit of an expense to them, believe it or not. You're a revenue generating expense to them. So you have to be prepared to have them, hopefully you guys are all on the same page and everybody's margin and mission are all working together. If that happens, it's great. But otherwise, you have to be prepared to gently fight for what you need to support what you need to support.
That's a great answer. Thank you, both of you. This is Emily again, and so I wanted to ask, we had another question come in that is, can you please explain a little bit more about the Teaching Health Center Act?
So the Teaching Health Center Act, it began in, as I said, the Affordable Care Act of 2010, and it was funded for about $230 million, and then in 2015 it actually was reauthorized, and it was to increase access to care for people who are geographically isolated or underserved. So they're in various settings. Some are in urban settings, some are in rural settings, or other settings like that. And there is eligibility requirements for that. It's a community-based ambulatory patient care setting. And so it's community-based, so it's not at a medical school. But you do have to have an institutional sponsor that is by the relevant accrediting body, i.e. for us that would be the ACGME. So often these are done by making that a consortium, an educational consortium, where both the healthcare community health center and then a hospital or an institutional sponsor have made an agreement to figure out how to funnel this funding into the Teaching Health Center to support the resident education. Is that how you understand it, Tom?
That's a great answer. You know, we're part of an FQHC, and I think these novel ways and these ways of looking at increasing funding, some of you may know too, FQHCs get enhanced reimbursement per visit rate, and so that also helps generate more clinical revenues. And so it is a unique way of looking at things, and if you're in a geographic situation that seems to fit, it is certainly something to look into. I know Hope Wittenberg, who's the lobbyist for STFM, is frequently working to maintain continued funding for teaching health centers and FQHCs, because those are primarily primary care, and what's the true primary care out there is really family medicine. I mean, a lot of people that are in internal medicine and pediatric residencies go on and do fellowships, and only a small proportion of those do primary care. So the true primary care providers in this country are family physicians. Sorry, I'm a little bit biased, but so those are great things to explore, and it's really hard to go over everybody's individual situation. But if you can get into that kind of a collaborative arrangement, working with your institution and your hospital, and perhaps an FQHC in your community, or like I am, become a new access point for an FQHC that's already been developed. If you can do those things, it is a great way to continue to fund your system and to provide excellent care and have enhanced resources to provide great care to those in need in your community.
Is there another question?
Yes, we do have, and I'll actually just say we got from our original listener question, he did clarify that he intended DOE as distribution of effort, but it sounds like the answer was he says it was very thorough and answered what he was actually after. So thank you for that. We do have one more question waiting for us, and it says, in starting a new residency program, how helpful do you think it would be to use financial data from other hospitals and residency programs when going into those discussions with hospitals?
If you could have a hospital similar to yours, it would be helpful. As Tom mentioned, when you have one residency program, you've seen one residency program, they're very different. Despite having common program requirements, it has to do with geographic area and how hospitals are set up. But if you say you were a community hospital and wanted to start a family medicine residency, finding out some of that financial data of other community programs may be very helpful to show you, the hospital, the benefits of that. There are some articles that have talked about that. Judy Powell's article, which I believe may have been in some of the pre-seminar material. If not, we will make that available for people. And there is certainly, the other thought is, there is a resource called Residency Program Solutions. It's a consultant group. This is actually through the American Academy of Family Physicians, but Residency Program Solution, these are expert program directors who can come for consultants to help people think about how their resources may best be used. Tom, you have other ideas?
That's a great idea. Some of the other things you can look at, so for example, there's a way of getting a sense of what academic family physicians are paid. There's a survey that's done by the Association of Family Medicine Residency Directors, or AFMRD, and anybody that is a program director or associate program director or aspiring under that way. I have to probably say I have a qualification because I'm on the board right now of that organization, but I think you should join it. And that salary survey is a very helpful tool to be able to, to explain to the hospital, this is what family physicians and academic programs like mine are getting paid. To looking at resources that you can. Residency Program Solutions also publishes the program of excellence data, which is they look at what a residency program should have in terms of bare minimums, but then also as a program of excellence. And so you can use those tools for when you're starting a new program to look at to get an idea about how much funding you're going to have. You're going to have someone who's kind of smart and is going to put together a budget with anticipated expenses and also anticipated revenues. And I'll just say be appropriate in your estimates of your expenses, but don't round down. You know, you have to be realistic with what your expenses are going to be and what people are going to need to fund your program. Don't sell yourself short.
I think here are some other thoughts on how can the Society of Teachers of Family Medicine help. There are going to be more resources for new faculty that will be available. The STFM Resource Library, for people who've been around for a while, we still use the acronym FMDRL, which stood for Family Medicine Digital Resource Library, but it's the Resource Library. It's on the website, and that's available. Certainly the other website, Family Medicine Careers, STFM has an Emerging Leaders Fellowship that is available for members to consider. There's a residency accreditation toolkit that has some resources regarding the program requirements, milestones, evaluation tools, some of the single accreditation for the osteopathic programs that may now be pursuing the joint or the ACGME accreditation, the single accreditation in 2020, for them to consider. Certainly STFM's annual spring conference, it's great. It's a wonderful conference. There's so much to learn and new, and to ask people certainly about if you have interest in finances or how do I, do this in my residency. You'll find someone there to talk to. It's really for the networking and mentorship that's developed. Emily, do you want to talk about the faculty development certificate program?
Absolutely. So just to let you all know that we're working on this. So this is going to be a new faculty development program, and this one is specifically geared towards residency faculty who are looking to do some online self-directed lessons and exercises for this kind of foundational training. Just about the overview of things that you need to know as a faculty member. There's a lot to take on, especially when you're newer to that. So we'll be coming out with those online modules. They'll be available as a certificate program for a fee. We believe in winter of this year. Kind of the hard launch date has not yet been determined for that. I also wanted to kind of back up what Wendy was talking about as far as that we also have some articles. If you all are curious about the government side of funding, do check out on the STFM website. We have an advocacy tab, and there's a lot of information about key issues and legislation. If you go to our advocacy part of the website and then look under graduate medical education, it has information on comprehensive GME reform, teaching health centers, Veterans Administration, just some of the Affordable Care Act kind of things. So there's a lot to dig around in there, and you might be kind of surprised what you might be able to find there. So definitely take a look at our website to see what you can see. We do have some articles on GME funding also under that new faculty, resources for new faculty section. So definitely take a look at some of those articles as well.
So are there any other final questions?
Right now it looks like we don't have any others. If you come up with something after the fact, feel free to send them to me, Emily Walters, so it's ewalters@stfm.org, and I'll be happy to pass them on to our panelists.
And we'd be happy to take those questions. So if you need further direction, we can certainly help you find someone to help you.
Absolutely. And I also wanted to add in that we will be sending out a recording of this webinar by email about less than 24 hours after we've concluded. So just so you all know, it's going to be recorded. It's going to be up on our website, and definitely take a look at that.
All right. So we wrap up then?
Yep, absolutely.
All right. Well, thank you very much, listeners. We appreciate you being here and contributing with questions. Again, email Emily Walters, ewalters@stfm.org with your questions, and we'll get some answers and some directions for you. Thank you. Tom?
I agree. Thank you so much for your attention. I hope this is helpful for you. We're happy to address any questions you have and just forward those through Emily. Good luck. Partner with the other program directors are really more than willing to help out with this. STFM resources and those things are amazing, but sometimes that networking and that working together, there's no substitute for that. And we're all in this together, and everybody will work to help you as much as you can.
All right, thank you.